entitled Improving Patient Experience in Virginia Hospitals and Health Systems. My name is Abraham Segrist, and I'm the Vice President for Quality and Safety here at the Virginia Hospital and Healthcare Association, where we've declared 2020 the year of patient experience across all Virginia hospitals and health systems. And before we get started with our presentation this morning, just want to review a few housekeeping notes. This morning's webinar is being recorded and will be shared with all participants at the end of this week. All participants are in listen-only mode. We will be able to respond to questions or comments that you type in the question box, and we ask that you do that throughout the webinar should you have a question, and we will plan to address them at the end of the webinar. Slides for this morning's webinar will also be sent out after the webinar. They are not currently available in the handout section. And finally, a feedback survey will be launched at the conclusion of the webinar, asking for your feedback on today's presentation. Today's agenda, I will do a quick review of the VHHA's year of patient experience and the objectives for this morning's webinar. And then I will turn over to our main presenter, Mr. Chris Occasion, President of Bon Secours St. Francis Medical Center, and his team there in Midlothian, Virginia. And then our partner, Carrie Brady, will do a few polling questions of our participants, and then we will take any questions from our participants and then adjourn by 10:30. So just a reminder, the Virginia Hospital and Healthcare Association is a statewide alliance of all the hospitals and health delivery systems across the Commonwealth of Virginia. And our vision is that through the power of collaboration, the association will be the recognized driving force behind making Virginia the healthiest state in the nation. Listed on the screen are all of the members of the VHHA, again, representing all hospitals and health systems across the Commonwealth. This year, we've declared it to be the year of patient experience, 2020. The specific objectives for the year of the patient experience from the VHHA are to, 1, identify, highlight, and celebrate all the good work and efforts that are currently underway in Virginia hospitals and health systems to improve the patient's experience of care. We want to also continue to link and integrate patient experience improvement efforts with broader quality and patient safety improvement efforts. We also want to be able to facilitate connections between hospitals and health systems and other stakeholders for the purposes of shared learning. And then finally, we want to support efforts to improve our individual hospital scores and aggregate scores on national patient experience measures, particularly HCAHPS. Today's objectives, we hope that you will gain insight into one Virginia hospital's efforts at creating and sustaining a culture of safety and service. We hope you'll see practical applications of key patient experience improvement tactics, such as leader routing and bedside shift reports. And then finally, we hope to solicit your input and feedback regarding your use of some of these key patient experience improvement tactics. So without further ado, I will go ahead and turn the presentation over to my colleagues at St. Francis. And Chris and Roberta, the presentation is all yours.
Okay, thank you. Good morning, everyone. This is Chris Occasion, and appreciate the introduction, Abraham. As Abraham said, I'm the president at St. Francis Medical Center. I've been here, it'll be almost 4 years this year, and I'm certainly passionate about patient experience and culture and how safety and service are inextricably linked. I'm joined by Roberta Azzo. She is our operations program manager, and blessed to have her. Roberta is sort of a jack of all trades, but has really jumped in and helped us out with some of the work around patient experience. Barb Gesme, who is our chief nursing officer, couldn't be with us today. She was going to join us, but she had a death in the family, so we miss Barb, but she's certainly a leader in this effort as well. Sorry, Abraham, I'm trying to move forward, but I don't believe I have the screen yet, or the webinar.
Now I'm giving it to you. Are you able to move it now?
Not yet. No, but you can move forward, and then we'll see if we can get it connected to me, and I'll drive once I get the steering wheel.
Can you all try it once more? Okay, I figured out what the problem is. Now I'm giving it to you. You should have it now.
All right. It looks like we got control. Okay, let me try to move forward. There we go.
Excellent.
Okay. So, we start all of our meetings with a reflection and a quote. And, I've heard over the years ago that this effort around patient experience is really a Sisyphean task, and I thought that was good. So I found this quote, and I think it really speaks to the work, and I'll just highlight the last line here. It says, Sisyphus teaches us to never give in to circumstantial disappointments or try to escape from the failures. Rather, accept failures the same way we accept our achievements. And that's, I think, certainly the case when it comes to this. We push the rock up the hill only for it to come back down. We've certainly experienced our failures and our successes, but we try to embrace both, and we learn and adapt. And I think that's what you'll hear today, and what I want to communicate. So in terms of culture, this is something I've developed over the years in terms of how do we sustain a culture of performance excellence in any area, but particularly in this. And I think it starts with hiring and keeping the right people, being very clear on your expectations and consistently communicating them, focusing on our key goals and then sharing results consistently as well, holding everybody accountable, including yourself, and then rewarding the good work through reward, recognition, celebration, both formally and informally. So you'll hear a little bit about some of these as we go through this. So part of the culture in ingraining that in what we do, and we've included the voice of the patient in our leadership agendas, and that's literally asking someone to bring the voice of the patient to the meeting, and it could be a positive voice, it could be a voice that where we didn't quite live up to expectations, it could be through leader rounding, or it could be through verbatim comments we get from our press scanning surveys. But we just want to make sure we're bringing that and reconnecting people to what we do, and that the patient is at the center of what we do. So that's just an example of a way that we've incorporated, the patient and our culture into what we do at our meetings. And then, as with regard to rewarding and recognizing and celebrating, this is just an example. We recently had our annual awards, and we recognized this is our ICU department for the service pillar in terms of outstanding results on their patient experience. It's just one way we formally are incorporating that reward, recognize, celebrate component into our culture. So this just shows where we are today, at St. Francis from an overall rating standpoint, and likely to recommend. We're close to the top quartile performance. We have been in and out of the top quartile over the last couple of years, and we have increased over the years, but frankly, as I said, we've dropped back a little bit recently. So we're always evolving, and again, that task of pushing the rock up the hill, sometimes it comes back down, and we're trying to learn from that. But this is where we currently reside today relative to others in Virginia. So our approach has been around this work is really focused, and it's really the three must-haves: leader rounding, purposeful hourly rounding, and bedside care report. We'll get into leader rounding and purposeful hourly rounding in a little more detail here, but I think, as we all know, this is not just about the patient's experience or they're being satisfied. This is really linked to safety. So to the extent that we're leader rounding effectively or hourly rounding effectively or conducting bedside care report, it's really about handoff communication, connecting with the patient, then using those connections through leader rounding as well to connect back to staff and reinforce the good work or provide a coaching opportunity. So that's the focus we've had for 4 years almost since I got here, and we've tried to continue to do these tasks and these interventions or must-haves more consistently and more effectively. So you'll hear a little bit more about that as well. And at the center of really all of those must-haves is AIDET, which I think we all know, but that's the tool that we're using that's centered around how we do purpose failure rounding, bedside care report, and leader rounding. So we train on this annually for people who have been here, as well as introduce this for all new employees at orientation. So getting into leader rounding, we started leader rounding, and initially from an accountability standpoint, we had our leaders documenting every patient that they rounded on, and they would turn that in. And I think we realized soon after that because you'll see later there was really a discrepancy between what we were seeing was being done versus what the patients were experiencing. It was really just a checklist. And so, we had 90% of our patients were being rounded on, yet, half of the patients when they were surveyed said that a leader rounded on them. Not that it wasn't done. I think it was just, how did we make sure it was a quality interaction? Because as we know, the patients during their inpatient stay may interact with 30 to 50 different individuals. So we're continuing to work on the quality of the leader round, and we'll talk a little bit more about that. So leader rounding today has really been more deliberate around focused patient populations, new admissions, discharges, focused patients. We know it's difficult, if not impossible, in a large unit for our leaders to round on 30 patients in the 2 hours or so time we've tried to provide as a sacred time and do that effectively. So we've been deliberate about where they are. It doesn't necessarily need to be 100%, but it may be if you get to 80% of the patients and it's those focused patients, then that's good as long as it's a quality round. This is something we've done over the weekends as well. We've had weekend leaders sign up in clinical and non-clinical to come in to round on patients to make sure that is occurring, and they have an opportunity to interact with their teams as well over the weekend. So as I mentioned, we redesigned the leader rounding process just last year after learning that the quantity of the rounds really wasn't moving the needle as much as we'd like, and created a different approach. And I'll turn it over to Roberta, because Roberta, I think, was really helpful in implementing this in a creative way to educate our teams and give them some good tools. So Roberta, you want to take the next slide?
Absolutely. Good morning. So we wanted to approach this new leader rounding refresh to be a genuine interaction, and we've learned through literature that the best way to get feedback from patients is to establish that personal connection. And so we brainstormed on how can we create that connection in a natural way so that it doesn't sound scripted, and also something that's easy to remember. So we developed this term, have a chat with our patients. And so have a chat stands for, has different meanings. So A is AIDET, which we just reviewed. C is that connection. Learn something about the patient. Make that personal connection with the patient, recognizing that is really our way of understanding how their experience is going. They're more likely to be honest and open if they feel that they've developed that trust with us. The H is high five. What are we doing well? Providing timely recognition to our staff, our support teams, and anyone who has been recognized by the patient. So we want to make sure that they are given that recognition as well. A is arcing up concerns in real time, so we can do those escalations real time, provide opportunity for service recovery in the moment, and really empowering our teams to have that ability to know what needs to be done so that we can improve the quality of their stay. And then finally, the T is for trends, and these trends can be anything, anything from cleanliness of the room or responsiveness concerns among the patients. And as a result, we've also implemented a couple of accountability tools. One is our unit directors summarize this feedback and provide it to us through reporting as well as in-person experience of care meetings. There's also a visual management board that's on each unit. You can see it pictured on the slide here on the right, where we've created a column to track leader rounding to provide that visual reminder. And as a result of this focus on creating the personal connections, really excited to share that one of our units has actually gone above and beyond and created a little, they call it a goat board, has to do with making connections with patients, one of which was that a patient had goats. And so they keep this board just to remind folks that making that personal connection really is important, and that no one wants to be in the hospital, but how can we improve their stay while they are here? So we're very excited to be doing this type of work with our patients.
Thanks, Roberta. I really do love the little board, again, just highlighting that personal aspect of the patient, and that's something that we always show off and the team is proud of. So next slide, this is leader rounding. I mean, this is just to show you, as I mentioned earlier, we do include the question in our HCAP survey, whether or not you were rounded on by a leader every day and during your stay. And you can see that was less than 60% of those, and then and where that was trending down, and then we since implemented the new approach to leader rounding in the tool, and we're still monitoring that to see if that is going to move the needle and get us back on track with that particular question. And so bedside care report, this is something that we developed a video to show what a good and effective bedside care report should look like, with some input from our Patient Family Advisory Council and Committee. We reinforce this through audits biannually, and of course that's included in new hire instructions for them to watch that video. So moving on to purposeful hourly rounding. Again, this was launched back in 2016 formally, and initially, again, our focus was on the hourly part of the PHR, as we call it. We even implemented VisAlert in 2017 on one unit to pilot it, which was just a clock that we asked the staff to hit once they rounded, and it starts the clock and countdown for the hour, and then it turns red when that hour is up, and it just is a reminder for someone to go in the room. We really found, frankly, little value in that. It was just another alarm fatigue issue, and it's something for the staff to think about or document. So we stopped doing that. We also, in the meantime, eliminated the purposefully hourly rounding documentation in the EMR, because that was just another, again, distraction from the clinical staff being able to interact purposefully with the patient. So we've taken that out of the EHR, because as we developed our patient care boards, which you'll see in a bit, that we wanted that hourly rounding to be documented on the whiteboard, so the patients could see when they were in last, and anybody going into the room could see that someone was in there about every hour. So with all that, again, we flipped the script, as we say, in January of 19, and really focused on with 5 Ps, as we'll get into that in a little bit, for purposeful rounding, and focused on quality over quantity. And this next slide, I think, is really impactful. This is really something that reinforced what sort of our hypothesis, what we thought we knew. But what this shows, this is an internal analysis of our patients and our data. And bottom line, this shows, regardless of how many times, the frequency that the rounding occurred on the question, because we asked both. We asked, did someone round on you hourly, and then also, or every 2 hours, or every, so often. And the question is also asked, how effective was it? So as you can see, and this is translating and correlating to their overall rating. Their overall rating stays very, very high, and it's only connected to the effectiveness of the round. So if the effectiveness of the round was very good, regardless of how many times they said they were rounded on, their overall rating was very high. So I think that helped us focus on the work that needed to be done in terms of the quality of the round. Not that the hourly piece isn't as important, but just reinforcing that when that round occurs, it's a quality one. And so this is a refresh that we've done. Again, I'll ask Roberta to jump in on this one too, in terms of how did we educate and create this, and then provide some accountability for it.
Absolutely. So the content wasn't new. It really just needed to be refreshed, revamped in a new and exciting way. So we educated, rolled out house-wide. Our nursing leadership assisted us with quarterly audits, just to ensure that do the staff know what the 5 Ps are? If not, let's target those particular areas. And then I also have to attribute a lot of the success that we've seen so far in the sustainment phase. That's the reward recognition. We are tracking this. We are recognizing those teams that are going above and beyond and improving. So we'll see in the next slide how we've seen an improvement. The red star indicates where we started this about a year ago. Again, there's many factors contributing to this, but I do believe that the sustainment component of it and keeping it top of mind has led to these results.
Thank you, Roberta. And then just, sorry, let me go back. The Patient Family Advisor Council that I mentioned, we've had this for a few years now, and just some highlights of what that group has helped us with last year and where they're focused this year. This is, this continues to evolve. We continue to recruit new members and make that group more impactful, and then connect them back with our staff and our leaders on the units. And this is an example of our patient care board. This is something that the PFAC has helped us with, and we again continue to work on this. We've changed this probably at least 2 times over the last few years, and again that continues to evolve. I'm wanting to run through this a little faster. I know I'm close to time, so we're wanted to close with I think a great patient story, and I think just a representation of when things go well. This is a patient who allowed us to share her story. So let me just share with you what she sent to us. She says, the St. Francis Labor and Delivery Department is beyond phenomenal. They became our family. I entered the labor and delivery floor on October 27, 2018. I was 27 weeks pregnant and diagnosed with PPROM. For those of you who didn't know, like me, that was preterm, pre-labor rupture of membranes. While I was in the hospital, not only did I spend Halloween, Thanksgiving, and Christmas with our newly found friends, the nurses and doctors arranged for my family to use one of the conference rooms to set up a Thanksgiving meal for our family. The night shift planned a surprise baby shower for our family in the common eating area on the 3rd floor. I had never spent a night in the hospital before my 6-week stay at St. Francis. It was the hardest time in my life, but we consider it our divine interruption. It has changed us in so many good ways. I am still in contact with friends and with many of the nurses. We frequently visit and bring goodies. I have also decided to apply to the Bon Secours Nursing School because I got the chance to see the incredible impact a nurse can have on someone's life. And I just share that with you because as discouraging sometimes as it can be looking at the data or some of the feedback we get, for the most part, we're doing great things. And I always remind folks, this is a unique business we're in. This is unique in that you can have that kind of impact on somebody's life like this young lady and her family. So I appreciate everybody's interest in this. And for those of you who are joining the call, certainly appreciate what everyone's doing in healthcare. And this is important work, but it's work that I think continues a daily effort. And that's why I want to just close with this. Again, back to Sisyphus here. Most importantly, no matter how much we lose in our quest, we must never back down till we fulfill our potential. Embrace the rock, be persistent, work hard, never give up, and be thankful for the journey. So again, I appreciate everybody's time. Look forward to answering any questions.
Chris and Roberta, thank you so very much for a very, very impactful presentation. I will go ahead and turn over now to Carrie Brady, who will run us through a couple of exercises with our participants. And I'll remind folks, if you have questions, this is the time to go ahead and type them into the question box.
Great. Thanks, Abraham. And thank you so much, Chris and Roberta, for that fantastic presentation. I wanted to point out that the Year of Patient Experience is grounded, as everybody knows, in these 4 essential foundations for success. Abraham, it appears I don't have control, so if you can forward, that'd be great. Leadership, patient and family engagement, staff engagement, and effective use of data. And what we heard today were all of those things coming together to have a very powerful effect. And that it isn't just one thing that you do, it's looking at all of these things, because you can't really get anywhere unless you have all of these foundations in place. So we had a couple of polling questions for you. Abraham, are we going to be able to advance to the polling question?
Yes.
While we're advancing to the polling question, let me tell you, part of our Year of Patient Experience. So our first question for you is, which leaders are routinely rounding on patients in your organization? And while you're answering that question, so Abraham, if we can open up that poll, those of you who are on our first webinar a month ago heard that as part of the Year of Patient Experience, one thing that we want to be doing on all of these webinars is gathering some statewide information for you on how other organizations are approaching patient experience. So last time in the assessment survey after the webinar, we asked people to suggest questions, and we had several questions asked about leader rounding, how it was being done, who was doing it, how it was being structured, and specific questions and so on. So that's why we're asking you these questions today. If you have other questions that you'd like us to ask statewide, please do put them in your assessment survey today so that we can include them on future webinars. So do we have an answer for this now?
I will go ahead and give folks 5, 4, 3, 2, 1. I will now close the poll.
Thank you.
And share the results.
Okay. So these are interesting results. So most of you do have rounding in place, and it's a relatively even split between who's just doing this with clinical leaders and who's doing it with clinical and non-clinical leaders. So for those of you who are just doing it with clinical leaders, it's an opportunity perhaps to expand the team that you're involving in rounding. And sometimes when you use non-clinical leaders, you have different kinds of conversations, and it also exposes them to things happening at the bedside. They have a fresh perspective, so that can be very useful. Our second polling question is about, to the extent that you have a leader rounding program in place, and 94% of you do, so most of you can answer this question, to what degree are you structuring those rounding conversations? Do you have no specific structure? Do you have a specific process, like we just heard of a chat, which I think is a brilliant way to structure that, without specific questions, or are you using more specific questions or scripting for that process? Again, with all of these, there is no right or wrong answer to these questions. We're just trying to get a sense of the experience so that you also can get a sense of what's being done statewide. So, Abraham, can you close that poll? Simple question.
Okay. Simple question, and we've had good response rates, so I will now go ahead and close the poll, and I will go ahead and share the results.
Okay, so about half of you are using specific questions, 30% with a structured process, and then fewer of you don't have a structure. So one request that we have for you, because again, this came from members based on our last webinar, was asking people if you would provide to Abraham what your leader rounding tools are. So most of you have either specific questions or a specific structured process. If you're willing to share that information with VHHA, and you're going to send those to Abraham, whose email, if you don't have it already, is on the next slide. What we want to do is gather that information, and then in the summary that we're going to do of this call, we would provide you with examples of questions and basically a repository of different kinds of processes and questions that are being used, because even for those of you that already have questions or a process, it's always good to see what other people are doing, and it might inspire you to make some changes to your own program. So anybody who's willing to share that, we would love to have you send that to Abraham. We also encourage you to share your reporting format, because of course if you're leader rounding, but you're not providing that information, if it just sticks with that one leader and doesn't go anywhere else, it's a missed opportunity in terms of quality improvement. So we'd ask that you share that for Abraham as well if you have a reporting format that you use for tracking and sharing information, because we think that will help everybody statewide. And then, so Abraham, if you can go to that, the leader rounding information request, and then one other thing that we wanted to ask you is we are looking for volunteers to help us in developing a Patient and Family Advisory Council guide. This is something that was developed recently by the Colorado Hospital Association. It gathers all of the best practice resources nationally. What we are looking to do is not reinvent the wheel here in Virginia, because we know there are ample best practices available nationally, but instead to revise this guide and put a Virginia-specific flavor to it, not only in the discussion, because the Colorado Guide, for example, uses a ski slope analogy and the difficulties of ski slopes, which really would not be applicable in Virginia, but also to have some Virginia-specific examples and best practices learned from Virginia hospitals. So if either you have a Patient and Family Advisory Council that you think is working effectively and you'd like to offer yourself as an example of some lessons learned along the way or practices that you're using, we'd love to hear from you. Or if you'd just like to be involved in reviewing the guide and making some suggestions, we're happy to have you involved in that as well. And now I'll turn it back over to you, Abraham.
Okay, Carrie, my apologies for my driving ability this morning. Can you tell me what you're seeing on the screen, Carrie?
I see the volunteers for the PFAC guide slide.
Okay, I finally figured out how to catch up with you. My apologies for that. I am now looking in our question box, and from our team from Bonsico, I do see a question. They said, your communication board has a space for every hour. Do nursing staff really fill this out regularly every hour?
Well, the quick answer is no. I mean, that the idea is that they're in there about every hour. Ideally, throughout the day, it's every hour, but at nighttime, we talk to the patients, set expectations that they're not going to come in and wake you up, but they're going to check on you. And then when they do, ideally, it's just an initial on the board. So again, it's a visual reminder for the patient as well that if someone's been in here in the last hour, they're likely to come in again. And the purpose, again, is to help to mitigate call bells for the nursing staff as well.
Excellent, excellent. I am trying to see if we have any other questions. I don't see any other questions in the chat box at this time. And so I am simply going to remind folks that we will continue this webinar series next month. On March 26th, we will be hosting Nancy Littlefield, the CNO from Riverside Health System. In April, we will be hosting the CEO and CNO from Augusta Health in Fishersville. And then in May, we will have Mr. Bush Bell, the Patient Experience Officer from the UVA Health System, with us. Please look to receive the handouts, the executive summary, and a recording of this morning's webinar in your email for everyone who registered for the webinar. We thank you for being with us. Thank you for the extra 2 minutes of your time this morning. And again, if you have leader rounding information that you would like for us to share with others, please email those to me at acegris@vhha.com. And if you're interested in assisting with our Patient Family Advisory Council Toolkit, also reach out to me. Thank you, everyone, and this will conclude this morning's webinar.